Hello everyone, welcome to another episode of clinical case discussion of varicose veins. Today we are going to see the basic definition and the pathophysiology and one important classification called CEAP classification. So what are varicose veins basically? Varicose veins are defined as multiple, dilated, elongated, tortuous veins of superficial venous system of lower limb, which are more than 3 mm in diameter. So by definition, more than 3 mm veins are called varicose veins. So less than 1 mm veins are called telangiectasias or otherwise called thread veins, and 1 to 3 mm are called reticular veins. All right. So now the classification of varicose veins. Before we go there, we need to have a broad overview about the anatomy of lower limb venous system that we have already covered in the previous video. So the long saphenous vein, short saphenous vein, and perforator incompetence are the main things which can happen, which can lead to varicose veins. And as we have already discussed just now, so 1 to 3 mm are called reticular veins, whereas more than 3 mm are called varicose veins. And thread veins or otherwise telangiectasia are nothing but they are less than 1 mm. Right? Next, we will see the CAP classification after we understand the pathophysiology of varicose veins. Now, coming to etiological factors, varicose veins can be broadly because of two main reasons. One is congenital and the other one is acquired. So, the congenitally, few people will be having absence of valves. We know the main essential component of veins are nothing but valves. In few people, there will be absence of valves that can lead to congenital varicose veins. And two important syndromes we need to remember regarding varicose veins are one is KT syndrome, that is nothing but Klippel-Trenaunay syndrome, and the other one is Parkes-Weber syndrome. Right. Now, coming to acquired causes, again, they are of two types. One is primary, the other one is secondary. When will you call varicose veins as primary varicose veins? When you do not have a definitive cause. So, it is nothing but a diagnosis of exclusion. So, it is an idiopathic condition where there is incompetence of the venous valves. Now, coming to secondary causes, it can be mainly because of three reasons. One, there will be any obstruction to venous outflow, or the valves per se are destructed, and rarely there can be high pressure flow whenever there is an abnormal connection between arteries and veins. That is nothing but your AV fistula. You know, arteries are very high pressure vessels, whereas veins are low pressure vessels. Whenever there is a fistulous communication between artery and a vein, it will be whatever the high pressure that is present in the artery that will be transmitted to the veins. Obviously, it will cause raised pressure within the venous compartment, leading to varicose veins. Now, coming to obstruction to venous outflow, the obstruction can be at the level of either lower limb or at the pelvis, or it can be abdomen. So, when can lower limb obstruction can happen? One is any trauma, and the other one is deep vein thrombosis, because there will be transmission or the transport of the blood will be from superficial veins to the deep veins through perforators. Whenever the deep veins are obstructed, obviously the pressure within the superficial venous compartment will be raised. So, similarly, whenever there is a huge mass sitting in the pelvis, for example, any large fibroid, uterine fibroid, or it may be ovarian cyst, or it may be iliac vein thrombosis. These are the pelvic conditions which can lead to obstruction of the venous outflow. Now, coming to abdomen conditions, one, there can be any colorectal cancer or any other abdominal malignancy, and the other one is IVC thrombus. Whenever there is a thrombus within the inferior vena cava, obviously all the blood will be pulled up in the lower extremities, causing high pressure within the venous compartment. So it can cause varicose veins. Now, when will be the destruction of valves? Normally, I told you, if this is a superficial venous system and this is the perforator and this is the deep compartment. Now, whenever there is a DVT present here, all the blood flow will be pulled up both in perforators as well as in the superficial compartment. That is why, because of the high pressure, there can be destruction of the valves. So ultimately, it will result in varicose veins. So these are the important etiological factors we need to remember for varicose veins. Now, I told you there are two important syndromes. One is Klippel-Trenaunay syndrome and the other one is Parkes-Weber syndrome. You can see here the patient has got a prominent and a conspicuous nevus present in one side of the lower limb. And if you observe carefully, this is the normal lower limb, whereas this is the affected lower limb. The affected lower limb is longer than the normal lower limb. And Why is it happening? Because of the bone hypertrophy. The lengthening of bone will be there, causing lengthening of the limb. So these are the important characteristic features of, one is congenital nevus, you can see here, and there is limb lengthening, and also there will be multiple AV fistulas. All right, right. Next one is the pathophysiology. So one word we need to remember regarding varicose veins is ambulatory venous hypertension. What do you mean by that? Normally, whenever there is a change, let's say for example in the resting state there will be certain pressure present in the lower limb. Now when the muscle is exercising or the person is exercising, there should be a drop in the pressure. If there is no drop in the venous pressure, that will cause the raised pressure within the venous compartment. That is called ambulatory venous hypertension. That means with ambulation there is no fall in venous pressure causing venous hypertension, right? Now, so you can see here, this is the healthy vein wall where there is optimal blood flow and there is no retrograde blood flow. Whereas in case of diseased vein wall, the blood is flowing in one direction, but because of the incompetence of the wall, again the blood is falling backwards. That means there is pooling up of the blood. Now, this is the most important flowchart we need to remember regarding pathophysiology. Whenever there is ambulatory venous hypertension, there is dilatation of the veins because of the pooling of the blood. Now, whenever there is dilatation of the vein, what will happen? The interendothelial gap is increased. Now, because of the increased interendothelial gap, there will be substances which will be extravasating from the venous compartment into the interstitium. So, what are the things that are extravasated? One is WBC, another one is WBC, and next one is high molecular weight proteins. Now, because of the extravasation of RBC, you know RBC is composed of hemoglobin. So, this heme will convert into, one is biliverdin and the other one is hemosiderin. Now, whenever this biliverdin is present, it will go and irritate the free nerve endings. So, whenever the free nerve endings are irritated, it will cause itching. So, this is the reason for your itching in case of varicose veins. Now, whenever there is extravasation of high molecular weight protein like fibrinogen, when it enters into the interstitium, it will convert into fibrin. Now, surrounding the vessel, this fibrin will form a tight cuff. So this is called fibrin cuff theory. Now, because of the extravasation of the WBC, this particular theory is called leukocyte trapping theory. Leukocyte trapping theory. This is one of the important causes for your venous ulcer. Okay, right. Now, you can see here, because biliverdin is going and when it irritates the free nerve endings, it will cause itching. Now, the other side is, whenever this heme is converted to hemosiderin, this hemosiderin is engulfed by the local dermal macrophages. Now, because of this engulfment of hemosiderin, there will be a melanocytic reaction that will be ultimately resulting in pigmentation. So, when you see any varicose veins patient, there will be a lot of pigmentation present in the distal part of the lower limb, and if there is ulcer surrounding the ulcer area, so this will ultimately cause pigmentation. Why is there pigmentation? Because of the engulfment of the hemosiderin by the dermal macrophages. Now I told you this fibrin is forming a tight cuff around the blood vessels. Now why is it important to know about this fibrin cuff? Let's say the normal thing that will be happening in case of lower limb or in case of any periphery is that now there will be exchange of materials between intravascular compartment and the extravascular compartment. So oxygen and nutrients will be coming from within the blood vessel to the interstitium, and also as it is a vein, obviously it will be whatever the metabolic end products, they will be, these metabolic end products will be taken from the interstitium into the blood vessel. Now because of the tight cuff, whatever it is present surrounding the blood vessels, so this is the cuff we are talking about. So now because of this fibrin cuff, it not only forms a cuff around the veins, it also forms the cuff around the arteries as well. Now because of this tight cuff around the blood vessels, what is happening? There is decreased oxygen coming from the intravascular compartment into the interstitium. Now, this hypoxia itself is one of the important triggering factors for your ulcer. So, it is one of the important cause for your venous ulcer. Now, the other side is that because of the decreased nutrients, I told you there will be decreased nutrients as well. So because of this decreased nutrients, but the intestinal needs a source of energy. That is why the fat which is there present in the intestinal will be broken down. Because of the breaking down of the fat, it will cause lipodermatosclerosis. This is an important complication which is happening because of the fibrin cuff surrounding the blood vessel. So, if we can remember this important flow chart, we can easily remember the complications of varicose veins. So, when someone asks you what are the complications of varicose veins, one is itching, second one is pigmentation, the other one is ulcer, venous ulcer, and lipodermatosclerosis. We need to remember them in a sequence to understand something called CEAP classification, right? So you can see here in the picture, this is the normal vein where the diameter is optimal and blood flow is in unidirectional. Whereas in case of varicose veins, you can see here there is a lot of tortuosity. So I told you when we learned about the this is the tortuosity of the varicose veins. So when we learned about the definition of varicose veins, they are abnormally dilated veins. They are abnormally tortuous veins, and also there will be elongation of the vein as well. Okay, because the in case of varicose veins, the limb length is fixed, but vein is somewhat elongated. That is why it cannot accommodate the fixed limb cannot accommodate the elongated vein. That is why they are becoming tortuous. Okay, right now let's have a look at CAP classification. CAP classification is nothing but C for clinical, E for etiological, A for anatomical, sorry, A for anatomical, P for pathological. Right. So what are the important C categories of CEAP classification? C is nothing but clinical. If you do not have any apparent signs of the venous disease, we call it as C0. Now, if there is only very small dilated veins like either telangiectasis or reticular veins, it is C1. Now, you can easily remember this is V and this is 2. So C2 stands for varicose veins and this is E and also this is 3. So you can remember 3 is for edema. So 3 reversed is nothing but your edema. So E is reversed, so it is C3. So you can see this is 1, this is 2. 2 for varicose veins. Now 4 is for skin changes. Again 4 has got 3 important components. 1, 4A, 4B, 4C. So 4A is nothing but I told you in the sequence. So one is pigmentation. So it may be either pigmentation or eczematous changes. So that is your 4A. And I told you because of the nutrient deficiency or deprivement, the local fat is broken down, which is causing the lipodermatosclerosis. So it is nothing but your LDS. So lipodermatosclerosis is class 4B, C4B. All right. Now, coronaflebectasia is nothing but ankle flare. Ankle flare is 4C. So, ectasia, it is dilatation. Fleb means vessel. So, it is dilatation of the ankle venules. So, coronaflebectasia is 4C. Now, C5 is healed venous ulcer. Already healed venous ulcer. Whereas if it is active venous ulcer, we will call it as C6. Again, in C2 and C6, there are two categories. C2R. R is nothing but recurrent. So whenever a patient is coming to you with the recurrent varicose veins, you call it as C2R. Whenever a patient is coming to you with the recurrent venous ulcer, then you call it as 6R. R is again recurrent. So whenever a patient is coming to you with the recurrent venous or varicose ulcer, it is called C6R. All right. Now coming to, so this is the different pictorial representation of your CEAP classification. C1 is nothing but telangiectasias or reticular veins. C2 is varicose veins. C3 is edema. C4A is pigmentation or eczema. C4B is lipodermatosclerosis. It is nothing but white atrophy. And C5 is healed ulcer. And C6 is open or active venous ulcer. Active venous ulcer. Now, this is just clinical pictures of different stages of our complications of varicose veins. All right. Now, so one important point we need to remember regarding lipodermatosclerosis is nothing but, as you can see from the picture here, this is nothing but a looking like a inverted champagne bottle appearance. So, where do you see inverted champagne bottle appearance? It is in lipodermatosclerosis. Inverted champagne bottle appearance. It is present in lipodermatosclerosis. Now, it's the same thing. So, till now we have seen clinical classification. Now, coming to etiological classification, we have only two types. When we have learned about the etiology, it is either primary or secondary. When do you call it as primary? When you do not have any definitive secondary cause, right? Now, coming to anatomical, so we know that this is the superficial veins, and you have deep veins, and you have perforators. So, whenever a patient has got only superficial venous compartment in incompetence, you call it as AS. Whenever there is perforated incompetence, you call it as AP. Whenever you have got both superficial and deep, you call it as AS plus D. And whenever you have got both superficial vein, that means either great surface vein or superficial, short surface vein incompetence, along with the perforator incompetence, then you call it as AS plus P, superficial and perforator. Now, coming to pathology, it will be mainly because of two mechanisms. One, it may be because of the incompetence of the SF junction or SP junction, that is saphenofemoral junction or saphenopopliteal junction. Because of the junctional incompetence, there will be reflux, or it may be obstruction, as in case of DVT.